I'll introduce myself. We'll talk about drug-induced liver injury. If everyone can sit, we'll keep it relatively informal. I have changed the slides a little bit from since I give this every year. So there'll be a little bit more information. There's a couple of interesting stuff about herbal and dietary things. So I'll just give you a rough kind of overview, and then what we do, because obviously we're particularly interested in this. So we'll talk about epidemiology, and then the DILI network. We'll talk about how you make a diagnosis, or how do you know, or how do you think that this drug is causing this injury. A little bit about the natural history of DILI. You would think it was an acute event that gets better, but that may not be the case. We have some genetic data, and as I mentioned, some herbal and dietary supplements. And then just a slide about LiverTox, which all of you, particularly the fellows, should visit the website when you get a chance. So I'll start with the case. It's a real case. So a 28-year-old gentleman comes with several weeks of kind of non-specific stuff, but then gets jaundiced, dark urine, pale stool. The only thing of note was that he was kind of overweight and was taking lots of supplements to try and lose weight over the preceding months. And in fact, it worked very well because he'd lost like 120 pounds, so he was a big guy. Smoker, really no drugs or alcohol. So when you examine him, he's jaundiced, but he's alert orientated. His abdomen's kind of soft, and really nothing much on exam other than being jaundiced. You do the workup, and pretty much everything's negative in terms of an etiology. Okay, so viral autoimmune stuff is negative. You can see his labs there, so he's very jaundiced. He's got a kind of a hepatocellular pattern, and he's got synthetic dysfunction, right? So he's kind of concerning. And in fact, he was concerning because he got worse. RNR went up. He developed evidence of encephalopathy, moved to the ICU. We listed him for transplant, and then we transplanted him. And you can see on the explant, he had massive hepatic necrosis. Obviously, it's difficult to tell what, but consistent with a history of drug-induced liver injury was the report. And he actually got better, but when he did get better, he decided to bring in what he was taking. So you can see that a lot of stuff there. So this is where it becomes difficult, and we'll talk about it a little bit later on about how do you know which of all these things he's taking, which of these actually. Yeah. He lost 120 pounds. Okay, so how big of a problem is this? So again, this is literature coming really from US and from Europe, looking at like hospital admissions, for instance. So you can see that in terms of, like, for instance, this case, we do like 8,000 liver transplants a year in the US, and probably 600 or so, a little bit more, from acute liver failure. Some of those are going to be DILI, acetaminophen, although we're not really interested in that in terms of idiosyncratic DILI, but some of the cases of acute liver failure will be from DILI. There's something called Hy's law, right, where you get jaundice and you get very elevated liver tests. So one of the things about registries for DILI is that we're really picking up the kind of severe cases. And remember, any drug can potentially cause a liver injury, but it's not just any prescribed drug. It can be over-the-counter stuff as well as like herbal and dietaries, and occasionally illicit drugs as well. When you look at it from a population basis, so these are studies from Europe, anywhere between maybe 14 to 50 per 100,000 or a million people. And the French study actually was done prospectively, so that's a pretty good number, 14 per 100,000. And if you extrapolate that, you get about 8,000 like severe cases. So these were patients that developed symptoms and jaundice in France, and a significant number of deaths. And similar in Spain. When you do retrospective hospital stuff in America, probably 1 to 2% of all hospital admissions are for a liver injury that may be from a medicine. When you look at the medicines associated with hepatotoxicity, right? So every drug pretty much has liver warnings in the big drug books. But remember, there are some drugs where you have to monitor liver tests. Okay, and this is important. I'm sure other people have done this as well. I've done some legal cases where patients develop liver injury when they were on a drug where it's recommended by the package insert that you should be monitoring liver tests, and people haven't been. So that's something that you really should be aware of. But remember, it's really a minority of drugs that actually cause DILI in susceptible patients, meaning most drugs don't. So we know this, and I'll show you the data that we have, that most drugs are kind of safe. But the drugs that do, there must be other factors that combine with taking the drug that predispose you to get the injury, right? So are there HLA markers? Is it based on your age or sex, if you're drinking, if you've got underlying liver disease. When you look at clinical trials, and one of the reasons drugs are withdrawn, or putative drugs are withdrawn, is because they make LFTs rise in the stage 1, stage 2 studies. And there's something to do with this daily dose. And again, when you look at the registries, it's very unusual to get a drug-induced liver injury from a drug that's given, and it doesn't matter which drug, where the dose is less than 50 milligrams. That's kind of an interesting thing, where really 50 milligrams seems to be this magic number. I like this pyramid because it gives you an idea, right? The number of patients that we see who have liver enzyme elevations is a lot, right? So now I'll tell you how we define DILI. But if you just think about people that take a drug and get an elevated ALT, there's going to be lots of them. There's going to be a lot fewer that get a liver injury with jaundice, and then obviously fewer still who get acute liver failure, and fewer still that die. So the highest law cases where you get a liver injury with jaundice, it's still important because it's probably, it's true, it's probably a 5 to 10% mortality, right? So if you get a drug injury and you get jaundiced, you've got to be concerned. So let's talk about the network. So this is the drug-induced liver injury network, right? So what it is, it's a cooperative agreement between several centers where the aim is really to understand idiosyncratic DILI, right? So this is not Tylenol. Tylenol is a predictable event. And what the goal is to enroll patients that have DILI prospectively, collect samples, and so we can do genetic studies later as well as clinical studies, and to really kind of standardize how we talk about DILI, about terminology, and then also how do you assess causality. And I'll show you some slides on that. So remember, there are drugs that predictably cause hepatic necrosis, which we're not really interested in, whereas the drugs that we're interested in, for no rhyme or reason, can cause this. So it's an unexpected outcome. It's not necessarily related to the dose. It's a rare event by definition. But having said that, you can kind of do some studies to get an idea that, particularly, for instance, augmentin or INH, we all have seen cases where the patient gets sick, particularly INH, and has required transplant. So it's probably about 1 in 500, and less so for augmentin, and less so for NSAIDs like diclofenac. The mechanism is variable, right? So it can be immunological, it can be metabolic, it can be a combination. And the phenotypes are important, right? So you can, yes, you recognize certain drugs can cause a certain type of injury, but even within that, there are some drugs that can cause any type of injury, right? So augmentin can cause a cholestatic injury, but also a hepatocellular injury, and sometimes a mixed patch. So that makes it difficult to study drug-induced liver injury. But I'll show you some stuff that we've managed to glean from 15 years of doing this. So this is it's the 4th iteration, so we just got funded again for the next 5-year cycle. So it's been going since 2003, so this is Dylan 4, and you can see the other sites kind of more on the East Coast. Duke is the coordinating center, and obviously NIH is involved as well. So one of the things that presumably attracted the people that organized this about Mount Sinai was that we potentially could enroll patients that are not Caucasian, right? So particularly when you're looking at genetic risk factors for DILI, it'd be probably good to have a more heterogeneous population. So Michigan and Indiana have a lot of Caucasian patients, and so I think that was one of the things that was attractive for us to them. But again, this is the 4th iteration. So what are the issues this time around? So, fine, we want to enroll as many patients as we can. So the more patients that you get, the more you can identify, okay, what are these risk factors for an injury from this drug? Maybe some mechanistic studies. And obviously the genetic stuff, the more patients you have, the more likely you are to be able to glean some genetic risk factors. We're still interested in getting biomarkers, right? So that gets more to the how do we make a diagnosis, right? Are there tests that you can do that prove that this is a liver injury from a drug, as opposed to just a liver injury from something else? Hopefully, and Dr. Odin is very involved in this, we'll putting together a trial to intervene in patients with acute DILI, right? So can we make it better? And then also, one thing we noticed in the last go-round, and hopefully this time round as well, is that can we put together some sort of strategy that we can identify, particularly with herbal and dietary supplements, kind of like an early warning that you're getting a signal that this compound is available and it's causing liver injury, so it's pharmacovigilance. So just to give you an idea, this is some data from registries throughout the world. So the Dylan is in the middle there, but it's kind of at least in terms of registry, the patients that they enroll, patients typically are kind of middle-aged, maybe a little bit of a female predominance. And because usually this is being done in hospitalized patients, most of the patients are hospitalized, and therefore the severity is going to be a little bit more than just a typical patient that you might see with just elevated enzymes in the clinic setting. The types of agents also then vary depending on where you're doing it, right? So in the Western world, it's usually like antimicrobials is kind of about 50%, but if you go to the Far East, again, maybe this is just a referral bias, the types of things they're seeing are much more likely to be herbal and dietary supplements. So people are taking like a natural supplement, and they're the kind of patients they're enrolling. So this is a little bit out of date, but this is from earlier this year. So in the US, Dylan, there's about 2,000 patients so far that have been enrolled in a prospective study, and I'll show you kind of a little bit of what they look like. So this is when we had like 1,500 or so, so it still holds true. I highlighted one thing. So 2/3 of the patients are jaundiced, right? So that means that what we're seeing in the studies that we're doing, they're on patients that have kind of by definition severe DILI, right? They're jaundiced. And because they're jaundiced, they tend to be symptomatic. So you can see the symptoms are usually kind of non-specific, but sometimes they can have pain, they can have fever and rash, and probably about 20%. And then right at the bottom there, the pattern of injury, about half of hepatocellular. And I'll tell you what that actually means, and then a quarter or so are cholestatic or mixed. But you can see there also about a bit more than half are female, and age is about 50. And then because we're seeing severe patients, if you just look at the median numbers of patients that when they show up, yeah, they got transaminases that are about 10, 20 times upper limit of normal, and they're pretty jaundiced with their peak bilirubin being about 9. This is a breakdown of the top 10 therapeutic classes. So in the study, what we find is that this was when we had about 1,000 patients. So about half are from antimicrobials. And when I give you a list of the drugs that we see, also you'll see that. But the next biggest class is herbal and dietary supplements. Okay, and again, there's some interesting stuff about that, which I'll show you a bit later. And then there's a bunch of cardiovascular, CNS, and analgesic type medicines. This is a list of drugs that of the top 10 drugs, and you can see the top 9 are all antibiotics. Okay, and diclofenac is the 10th. This is again a little bit out of date, but the other thing you'll notice is a lot of these drugs are old drugs. All right, now that speaks a little bit to how these things are being tested and whether even at an early phase new drugs are being withdrawn. Having said that, some of these new immunomodulating agents, they also may be associated with DILI, but the typical things that we see are drugs that are given out and have been given out for many years. What happens if you get DILI? So again, in the network, because there is a kind of a referral bias and we're seeing kind of sicker patients, bad things happen, right? 7% of the patients died. Now some of them died because they just were given a drug and they had cancer or something, so they probably died of the cancer, not the drug. But a significant number of patients died, and as I say, because it's usually patients that are hospitalized, most of the patients that we see are hospitalized patients, and some got transplanted. And there is this entity about chronic DILI, meaning you can get an injury from a drug that doesn't seem to improve within a few months, and I'll show you a little bit of data about what happens to those patients. So let's switch to diagnosis. So for the purposes of making a diagnosis of DILI, it depends on how you define it. There's not a blood test that can prove this. So for our network, for instance, the injury has to be within 6 months. It has to have an AST or ALT more than 5 times the upper limit of normal, or alkaline phosphatase twice, and the DILI has to be more than 2.5, and it has to be on 2 separate occasions. And when you get the labs, then you can kind of characterize the injury, and we use this R ratio, which tells you whether it's hepatocellular, cholestatic, or mixed, depending on the ratio of the ALT to the alkaline phosphatase. Okay, and that's just useful for us in terms of when we do descriptive studies to describe the pattern of injury. So how do you make a diagnosis? Well, this is a little bit like the RUCAM, and I'll explain what that is in a second. So basically, you make a diagnosis based on collecting data to exclude other things, and obviously there needs to be a temporal relationship of taking the drug, and then a positive D-challenge helps, right? Meaning you took the drug, the numbers went up, and when you stopped taking it, the numbers came down. So that's useful information. And then obviously excluding other things that could cause liver injury. And then it's helpful to know, well, this drug has caused injury before, right? So maybe online, or as say LiverTox, or there are other studies, or even in the product labels, this drug can cause this kind of injury. And very rarely would you do a rechallenge, but occasionally it happens inadvertently that someone gets put back on the same drug. So that's very good evidence that this is the culprit. When you exclude other causes, it depends really, how the patient presents, right? So if the patient has an acute hepatocellular injury, really you need to exclude the things that can do that, right? Viral hepatitis, and we've seen several cases. Dr. Grayball's very keen on this, on hepatitis E, for instance, right? Excluding hepatitis E. Rarely you would do CMV, EBV, but at the bare minimum you need to exclude hepatitis A, B, and C, right? When you have an acute hepatocellular injury. Obviously, if it's cholestatic, you want to exclude diseases of the biliary tract, so you'll need some sort of imaging. And occasionally other diseases that really you wouldn't necessarily think of can cause liver injury, like heart failure and ischemia, for instance. Alcohol, topic for another day, but usually that's not so difficult to exclude. But autoimmune disease and some kind of metabolic diseases, and also one of the problems we have is, okay, very rarely do you have someone taking one drug. So maybe which of the drugs that they're taking did this, right? So it's important to get a good history first off, because most patients don't necessarily admit or what kind of herbals and dietary supplements they might be taking. So you really need to ask them about that. So this paper just came out. Not you would do this clinically, but it's kind of an interesting study where they basically looked at a toxicity assay using monocyte-derived hepatocyte-like cells taken from patients that had DILI, and then comparing them to controls. And then looking to see, look, can they say this drug did it? So what they did is they took the patient samples, their methods, they basically do a panel of different drugs. They have healthy controls, and you can see here there's a peak with flupertine. I don't know what that is actually, but that's very good evidence that this drug caused this injury. Okay, and then there's some genetic studies that say yes, this patient had an HLA haplotype that fits with this particular drug injury. So there are ways of doing it, although these are obviously not ready for clinical use.
Can you flesh this out a little? So they got blood monocytes and they differentiated them in vitro, so they had a hepatocyte-like phenotype, and then they tested them? Yeah.
But yeah, this just came out. It's actually not even in print yet. It was Bob, one of the other my colleagues in the network, sent it to me, and it's an interesting concept. The results look very good, like 92% sensitivity, 100% specific. So, and it was done retrospectively. So again, this just came out, so remains to be seen.
So when they integrated with the drugs, I'm curious how they picked the drugs they were going to test, and did they use a concentration of the drug that you would expect to see in vivo?
Yeah, it's not out in print yet, but I have it's interesting, although a topic for another day, that we've had some collaborations where there have been some issues where the results look very good and then we do it again and it's not so good. So talking about collaboration, so this is a collaboration we've had with people in Europe, and again the goal is to get as many samples as you can, right? When you're doing genetic studies or when you're looking for biomarkers, right, you want samples of patients that have had injury, and one of the problems is that we have obviously injury from lots of different drugs. So is it really something that you can kind of mix? Should you not just look at augmentin cases or INH cases? Can you just look at everything? It's going to be kind of messy. So one of the things is to collaborate with this safety consortium, and we've had a little bit of data with these guys. So looking at, for instance, HMGB1, which I showed last year actually, and there's been a bit more data on that, but maybe not as good as we thought it might be. So again, remains to be seen if we can identify a biomarker that DILI as opposed to something else.
Now, when you say not as good as, so acetyl HMGB1 looks pretty good there. Well,
right, but this is, I say, this is based on one study. When this is repeated, it isn't as good. That's right.
When it was repeated by a different group of people, or?
So,
It was the same group.
well, okay, so there was someone was can we say this? I think we can.
They retracted their publication.
Wow.
It was not this particular publication, but a related publication. So there's a lot of controversy now about how good the acetylated HMGB1 is in any type of injury.
Okay. All right. So assessing causality, right? So how do you know that, okay, you have someone with a liver injury that took this drug, and you kind of suspect this was a drug-induced liver injury. So how do you assess causality, how certain you are? So the way we do it is two methods. One is the RUCAM, which is about 25 years old now, and I'll show you a slide or two what that actually, how that actually does it. And then we use expert opinion, right? So we have three of us who basically look at the cases blindly and come to an opinion, and then we reach an opinion if we differ by consensus, but usually by email and conference call. And then we use like a 5-point scale, right? So this is kind of like legal scale where we think it's definite, highly likely, probable. So 1, 2, and 3 would be more likely than not this is DILI, and 4 and 5, yeah, it could be, but likely not. And then whenever it's 4 or 5, we have to have an alternative reason why they had a liver injury. And then the RUCAM, it is validated, but it's validated for prescription drugs, not for herbal and dietary supplements. And what it does, it uses weighted scores. So like how quickly the injury happened, was there a decrease in LFTs after the drug was stopped, and you get points for these things. Are there other risk factors? Were they on other drugs? Did you rule out other causes? And then again, they have a scoring system that they use. So here it is. And again, it came out in 1993, so 25 years old. And one of the other things we've been trying to do in the network is to come up with a better scoring system, and it's very difficult. So for the time being, we still use this in terms of for publications as well. I'll keep going. And then you can compare the two, and they're pretty good at agreeing with each other, but there are outliers. So that's why we continue to use both our system and the RUCAM. So treatment, I put this in inverted commas, but maybe in the next few years I'll be able to, when Dr. Odin gets this trial going, show you that there is treatment for DILI, but really there isn't, right? So the treatment options are to stop the drug. For situations where you have a acetaminophen, obviously we have NAC. And then there are some other examples of using other things in certain situations like IV carnitine for valproate, but really there isn't treatment. The treatment is to support the patient and hope the liver gets better. And we're still at that stage. I'll leave that. Okay, so
I'll just make a comment since the treatment list is very short. There are probably about 6 or 8 companies that have very early stage treatments that will enhance regeneration, liver cell growth. This would be ideal, and actually any acute liver failure. The challenge, so I think 10 years from now, but maybe not much sooner, you'll have a list of treatments short term. The challenge from the clinical trial perspective is these cases are so intermittent and so varied that it's a very to be doing a clinical trial when everybody looks different.
right.
You know, you have to adjudicate carefully and all of that to set up, you know, hundreds and hundreds of trial sites to capture enough patients.
No, I say, I mean, we've had discussions the last year or two actually. Partnering potentially with pharma really has not really come to fruition,
Right.
and that's what we're struggling with. Is that okay? When you do this, is it only going to be for instance, the acute hepatocellular cases? What do you do about the cholestatic cases?
Right.
So the heterogeneity makes it difficult.
And of course, things like FXR agonists, PPAR, Delta, all of these NASH and PDC drugs, you could establish a rationale. And I think there, what you'll see is that drugs will be approved for, you know, the main indication, and then folks like us can propose
Right.
investigator-initiated trials, or maybe through the DILI, to take a drug that's already approved. Part of the problem is when you do a drug trial with a new drug, if you have complications of the disease or the drug, they end up in the label.
Right.
And so it's much safer for companies to get the approval for the primary indication, and then they can do, you know, small trials with the indications. So stay tuned.
Okay, I'm running over. I'm going to have to speed up a bit. Okay. I mentioned this previously. So remember, what we're doing is we're enrolling these patients, and most of the time what happens is that we enroll them and then we follow them for about 6 months because we want to make sure they get better. And what happens is that most of the time they do, but some patients don't. They seem to get like a smoldering injury that just doesn't seem to be better at 6 months. So we've continued to follow those patients. And again, there's the criteria that we use to say that this is chronic DILI. And there's a paper that came out in Gastro a few years ago just to show what happens to those patients. And I'll just cut to the chase. Of the patients that we've been following, about 10% who had developed chronic DILI then went on to either death or transplant. And there are some correlates of who is likely to get chronic DILI, right? So a more severe injury, there may be a signal that Asian patients, and some of that may be to do with what they're taking, were more likely to get this. And cholestatic injuries, right? So if you have a cholestatic injury, that's much more likely to become chronic as opposed to a hepatocellular injury. And the figure is it's about 20% of people get chronic DILI, meaning they got an injury, but it didn't get better at 6 months. Let's switch to genetic risk factors. Basically, again, it's difficult to study this, but there are certain HLA alleles that are associated with DILI. And again, lots of studies, and usually GWAS type studies, although nowadays we're doing whole genome sequencing, that you can identify a signal. And I'll just show you some Manhattan plots because they just look nice. So this, so I was mentioning Paola Nicoletti earlier, so this is a paper. And again, it depends on which patient population you're looking at, but this HLA-A3301 is associated with, like, for instance, terbinafine, fenofibrate, and ticlodipine. And then you can identify polymorphisms that might predispose you to DILI from statins. So here's the terbinafine, and you can see chromosome 6 is the HLA one, and you can see that spike. And similarly with other drugs like flucloxacillin, a very big spike here. So this HLA-B5701, if the patient has that, it's a very high risk of getting DILI from flucloxacillin. Similarly, azathioprine, this is not a chromosome 6, it's on chromosome 20. And so you can do similar studies, and the problem again with the network is that, you know, maybe we'll have 20 cases or 30 cases, and it's difficult to glean a genetic signal when you only have so few cases. We'll switch next 5-10 minutes about herbal and dietary because there's some interesting data coming out of this, right? So we're aware of this, that lots of people use these things, and oftentimes they won't admit that they're actually taking it. And as I mentioned, particularly in Asian populations, you'll see a lot of this, and we've tried to enroll more Asian patients in particular because of this. Again, everybody probably familiar with some of the things listed here, right? So particularly on the left, but on the right, there's some things that you may be not familiar with, which we've seen, like Herbalife and Hydroxycut. So these are supplements that people are taking really as kind of sometimes bodybuilding or, you know, weight loss, and we're seeing a significant number of these cases. So just to highlight one, so we were involved, we had a couple of cases of this Oxylete Pro, so there's legal ramifications for this as well. And what they found, and this was a cluster of cases, so Oxylete Pro is a supplement that was initially marketed and then withdrawn because it had cardiac toxicity, and then reformulated, so this was probably 5-6 years ago, as a kind of a weight loss, bodybuilding type supplement. And what people noticed was there were cases in Hawaii, and then also in the military, right? Military people, they would be presumably using this kind of stuff. It's kind of, I say, for bodybuilding. And they noticed that a bunch of people started getting acute liver injury, and, you know, significant injuries such that people died or needed transplants. So there was in the military, and then this is the cases in Hawaii. So there were 7 cases. You can see at the bottom there what happened to these people. That 1 died and 2 got transplanted. And then in our network, very similar, 2 transplanted out of 7. One of them was here actually. What they did is then this was then withdrawn, but there I say there are legal ramifications. So one of the things I was talking about earlier about pharmacovigilance, could we have identified this, right? Because we're enrolling cases, and oh gosh, I saw a case of this with this compound, and someone else in California sees another case, and someone else sees a case in Michigan or elsewhere. And this is a product that's freely available. Then maybe we can put into place some sort of mechanism to get this withdrawn earlier because we're picking these cases up. When you look at herbal and dietary supplements as a whole in DILI, it's kind of 2 groups, right? One is like the bodybuilding type, and the other are everything else. And the bodybuilding types are almost always anabolic steroids. So there will be a paper coming out looking at the clinical consequences of that. But in general, anabolic steroids are pretty benign because they give you a bland cholestasis, and most people, well, in our network anyway, everybody gets better. The other herbal and dietary supplements are the ones that are concerning. So here you go. So you can see what happened to these patients. So the bodybuilding, none of them died. Nobody needs a transplant. But the other stuff, there's a lady in the ICU currently who probably had a liver injury from Chinese herbs. So people get sick from herbal and dietary supplements. And this is what I want to show you. So this is hopefully going to come out soon. So we've noticed that is there an issue? Remember that the HDS industry is not regulated like prescription medication. So could there be a situation where you're taking something, but do you really know what you're taking? So as I mentioned, the regulatory environment, because they're herbal and dietary supplements, it's really essentially unregulated. So what we do in the DILI is that we actually collect the compound, right? So we have patients that have an injury, we have clinical data on them, they've been adjudicated, the causality has been adjudicated, we have RUCAM scores, we have lab work, and then we have the product. So can we then go back and analyze the product and see, well, look, there's a label on the product, what's in the product, according to the people who make it, according to what we do when we do mass spec on it, okay? And then you can go back and see, look, are there adulterants? So what we did is, this will hopefully come out soon, but it was presented at the last ASLD. So you take everybody that's enrolled in DILI at that point, and the ones who are taking herbal and dietary supplements, the ones that we have specimens on, we basically analyze the products in patients that have had a DILI, probably from this product. And again, you can break it down into how many people are taking how many drugs, and obviously, a significant number of people are taking more than one. So it becomes difficult, right? But even when you look at one of these things, there's more than one compound in each pill. There may be 30 sometimes. Okay, so it becomes very difficult to study this, but I'll show you what we found. So again, you can break it down into why these people are taking it for general health and bodybuilding, weight loss, unknown for other reasons. And what you find is that, so just look at the right side there where it's inaccurate label. What this means is that what's said on the label doesn't match to what we found, okay? And it's about half, right? So the mislabeling is about 50%, and it depends on the type of compound. So again, for bodybuilding, it's about 80%, right? So there could be adulterants in this that they're not on the label, and I'll show you how this actually works kind of clinically as well. So the message is that 50% of the time it's mislabeled, okay? And then when you assay the compounds, you find stuff that are known to be hepatotoxins, right? So I've listed some of these things here, and even sometimes in these herbal and dietary supplements, you find prescription drugs as well. So people, the good example is the patients with hepatitis B, right, who take Chinese herbs, and the ALT, AST get a little better. Maybe the HBV DNA comes down because there's usually lamivudine in the product. And again, it just breaks it down by type. But I just want to show you this one case. So this is an example of a 24-year-old guy who gets jaundice with a hepatocellular injury, and he's taking a bunch of products. They have kind of interesting names, Animal Flex and Optiman, all this kind of stuff. All right. A little bit of maybe a clue. There's something called TC3 tamoxiclone. Okay, and there's the picture of what happened to him clinically. Right. So he had he got pretty jaundice. It really went up to 9. Transaminases went up, and then gradually gets better. Right. Takes over a few weeks, gets better. So here we go. This is the stuff that he took, this TC3 tamoxiclone. And when we look at the label, they're the things that are written down. So some of them I recognize, some of them I don't. And then when you look at the mass spec, what's actually in there, none of them are actually in there. Okay. But then, this is the MAC, and you then look for other things that potentially. So that we partner with this guy in Mississippi who is at the Center for Phyto something. Anyway, what he does is he basically has a big lab where basically he can give you a readout of what's in whatever you give him. Right, so he grinds it up, puts it in the machine, and it spits out whatever's in there, so up to like 1,500 or 1,600 compounds, as well as prescription drugs. And so what you see here is you see a spike, and I think it's that spike correlates with tamoxifen, right? So what likely happened here, and tamoxifen is a known cause of that type of liver injury, is that he likely got injury from a herbal dietary supplement, but actually from tamoxifen. Now that has implications for us as a network, right? Because we've been enrolling patients and assessing causality based on what we think's in it, but maybe that's not the case, right? There are actually other things in it, so that's become a big issue for us.
There have been cases of liability for this,
and ongoing as well. The Oxy Pro is a big thing currently.
But I don't know if you said it, I missed it. The FDA doesn't regulate these things. That's the problem. Yeah.
So this the guy in Utah, right, Orrin Hatch. So he's the big roadblock in Congress. I assume a lot of things come from Utah, right? So these things, because they're not classified as drugs, they're not under the same scrutiny. Okay, I need to quickly finish up. Okay, so we have some other things that we're particularly interested in at Sinai. So one of the things we kind of thought about was that, okay, maybe we're doing this kind of the wrong way around, right? The way we're doing it is that we're identifying a case once the patient gets jaundiced, or once the patient gets high liver enzymes, and then we go back and say, okay, you were taking this drug. Would it not be better to get a group of patients that are taking a drug and then getting blood work done for whatever reason prospectively, and then identifying them, right? Because then you have a control group of patients that took the same drug and yet didn't get the injury, right? That would be very good. But then, can you identify a drug where you know things are going to happen? Because if it happens so commonly, would you use that drug? Well, there are some situations, right? So what we noticed was that in patients who've got urological malignancies, they're given chemotherapy, and oftentimes one of the problems with chemotherapy is people get like 6 drugs. With urological malignancy, usually you only get 1 drug. And these patients are being followed because they're cancer patients. So what we've done is we've partnered with people in urology and in oncology as well to follow patients prospectively. And Chiara's here, right? Yeah. And Stephanie's here. Sorry, right there. Our coordinators have been working very hard to basically collect samples from patients on these particular drugs, and then it's about a 10% risk of these patients getting elevated liver enzymes. So that's going to be a very valuable resource. So we have a group of patients that got liver injury as well as the controls who are taking the same drug. Okay. We're also looking at DILI and hepatitis C, right? So can you say that if you have underlying liver disease, and it doesn't have to be hepatitis C, maybe fatty liver disease, are you going to more likely to get liver injury? And this comes up clinically sometimes, right? PCPs or someone will call you to say, well, look, I have so-and-so, I know he's got fatty liver disease or he's got cirrhosis, and I want to give him a statin, or I want to give him something that's known to cause liver problems. Is that safe? There's some retrospective stuff that suggests that maybe it is, but we'll have some prospective data, which that's what we're looking at now, because we've enrolled probably about 120 patients that have chronic hepatitis C. Then also had DILI on top. Okay, and there's some interesting data also that the hepatitis C RNA drops when you get an acute injury on top. So there's kind of interesting stuff when you look at viral loads when patients get another injury on top of having chronic hepatitis C. We've also noticed, this just got published recently, that we're always thinking about hepatocellular injury or liver tests going up. Can there be structural changes to the liver because of DILI that get better? Yes, there may be. So the paper just came out in CGH looking at secondary sclerosing cholangitis from DILI. And then I was mentioning to Arpan earlier about, does liver biopsy play a role in the diagnosis of DILI, right? So if you have someone like the guy that we have currently, is it useful to do a liver biopsy on him? Because we're not certain what's going on. So again, we're looking at that of the patients that we've collected prospectively to see if liver biopsy plays a role in diagnosis of DILI. And then obviously lots of case series looking at various drugs and what the clinical signature is with them. So this is the urogenital database, and just to show when we did it retrospectively, this was the data that we used to start this prospectively. It's about 10%. So 10% of patients on this pazopanib, for instance, had evidence of elevated ALT. Actually, with pazopanib, it was at 25%. But overall, it was about 10%. So this is a good patient population to study, right? These are patients that you are following prospectively who are getting exposed, some of whom are getting the injury and some of them are not. Just to show you a bunch of papers that came out, and I just, since we were involved in some of these, just listed them there. So future plans for us is to continue with this urogenital DILI database. And then, as I mentioned, this will hopefully get going maybe next year because the study's being designed now. So what we did in the last iteration is, so you have patients, because we have a 6-month window before we can potentially before we can enroll them. What about patients that show up where maybe you don't have all the data yet? You don't know if they have DILI. You start doing the workup, but you are collecting samples, right? So maybe the mechanistic studies, they're better off doing it at the acute phase, right, rather than later on. So we had an acute DILI study where we enrolled patients within 16 days of injury. And what we realized is actually we've got quite a lot of patients that way, right? So you have enough patients, you can do an intervention study. So as Scott mentioned, we talked to pharma, and we have some maybe 3-4 things that we could potentially try in a prospective study. So that will hopefully start next year. And I don't have time to go into this, but we've been in touch with the Department of Health in New York. So they had a very successful program looking at lead poisoning or lead paint. And what they had done is they set up, just in New York City, a system where they flagged high lead levels in children, and then had people going back to see, okay, what was their exposure? And they were able to identify where this potential lead poisoning outbreak came from. So could you do something similar for DILI, right? So you partner with maybe Department of Health, fine, but we have people that are interested in DILI throughout the country, but also who else would be interested? Well, toxicology people would be interested, right? So you have people, I mean, everyone has a toxicology center, so they actually collect data where someone had an injury likely from something. So maybe partner with them, and can you pick up a signal that, yeah, there's 3-4 cases of an injury from this particular compound. So again, that was part of our grant, actually. That would be something else that we're hoping to get over in the next cycle. Just to finish off, so again, I mentioned this, LiverTox is probably the best thing that's come out of the network. And I have to give Jay Hoofnagel all the credit for this. So what he's done, together with some people at NIH, is that they have a website, right? So this is livertox.nih.gov. And when you go to that website, this is what it looks like. So you can search for a specific medication, and there are more than 1,000 things in here. And what you'll find is that, and not just prescription medicines, even the herbal and dietary stuff. And when you click on augmentin or cephalosporin or something, what will come up will be a description of what kind of injury this caused. It gives you case histories, it gives you pathology, Dr. Field, and a bunch of references. So I always use this as well, because when we're having our causality call, I mean, it's very difficult to remember every single drug. So when we have a case, I'll go to here to see, okay, does this fit with the description previously? Right. So these are very useful for the fellows that say, if you see someone and they're taking this, and you think, okay, does this cause this type of injury? Most things that you'll come across will be in here. Okay. When I wrote this as 800, it's more than 1,000 now. As I mentioned, there's links to things, and there are as well as pathology slides. And if you're interested, you can actually enter new DILI cases. So just sum up. What I would say is that, it's for the purposes of the network, or for us, it's something that we see relatively commonly, right? We've been going. We probably enroll about 24 to 30 cases a year, and that's just us, and everyone else is doing something similar. So it's 2 a month, something like that. There are risk factors, but again, we're kind of noticing that in years gone by, people would say, well, if you're older or very young, you were more at risk, or if you were a drinker, or if you were female. That may not be true, and it's probably more of a genetic thing on a combination of factors. Diagnosis, we talked about, you have to kind of exclude several things, and for us, as I say, we're more interested in obviously idiosyncratic DILI, but how does it manifest, and then when we have enough samples to do studies on mechanisms and as well as genetics. Just take-home messages, the things that are common are antibiotics, and then the next common is herbal and dietary things. There is a significant mortality. Again, it's a referral bias, but this is not a benign disease. And even in the patients that seem to get better, they can still get like a chronic injury, and it's not always all like an autoimmune type thing. The HDS stuff, this mislabeling business, is kind of obviously very topical as well. And our future plans hopefully will be an intervention study, and as I mentioned, LiverTox, something for you guys to look at. And then obviously call me and Dr. Odin if you have cases. Thanks.
Quick question. So patients that present with acute liver injury, it's usually, if it's isolated DILI, that's the etiology of it. Usually 30 days is enough time to withdraw the drug to see enough the liver injury improve.
30 days, yeah.
30 days. And at that point, is that how do we refer to the DILI network? Is that when we...
No. What you should do is that you have a case, like, for instance, we have a case that came in overnight, right? Where usually comes from the hospital, they've done a workup, they don't know what's wrong, but the numbers are high. You should call me then, right? Because again, we're interested in acute cases. The acute cases, the criteria for us to enroll are a little bit less strict, and so we realize that we'll have some patients that turn out not to have DILI, but we'd rather have that early rather than late. I got you.
Is there a, so with herbal and dietary supplements, is there a signal for the influence of polypharmacy with those? Because I feel like people who take a lot of the herbals, usually they're on a lot of them. They're like,
Yeah, as you can imagine, that's difficult to prove at this point. You would think it is. At the moment, we're kind of, it's very difficult, right? Because, as I say, even the case that I presented at the beginning, if you count up what he was taking, right? He's taking like, I don't know, 30 different products, of which everything, there's like 30 different compounds in each product, right? And then I just showed you that some of these are mislabeled, so there may be stuff in there we don't know. So it's difficult to tease that out. Sorry.
do you think this data is going to be helpful? It seems like an area where some regulation is needed. So you feel like this.
I mean, what's going to change someone's mind if some senator's kid or something gets this, right? That's what's going to change someone's mind. You're right, it needs regulation, but there's no kind of impetus in Congress for that.
I've had some situations where we have patients on chemotherapy that got DILI, and then since it was either a new drug, it may have not been reported, at least in LiverTox. Like, what would you kind of do in that circumstance if like it was like would you like contact the NIH's clinical trial and look to see if it's caused that in like phase 1, phase 2 trials, like liver injury or?
So sorry, you have a case and you think it's from this drug and it's not previously reported.
Like if it's like if it's a chemotherapy agent.
Yeah, so there is a mechanism in place for that, right? So the FDA has that. They have that MedWatch that you can do that. Otherwise, you can tell us.
I think you mentioned that DILI tends to depress hepatitis C RNA levels. I don't know if it's possible to expand to include hepatitis B, but I think hepatitis B may be even more sensitive to sort of the health of the hepatocyte than hepatitis C. So if you see this effect on hep C, I'm just guessing you might see it on hep B as well. So I just put that out there as something you might want to be on the lookout for. I've seen data that if you look at hep B viral load, just comparing people who have liver steatosis to people who don't have liver steatosis, just steatosis really depresses the hepatitis B replication. So, it might be another thing to look at if you have any room to expand.
No, we would. One of the problems is we don't have a lot of patients that have hepatitis B that had DILI that then got enrolled. Just have a lot more hep C. Mm-hmm. But yeah, definitely worth looking at.
For a lot of the herbals, I found that they're not on LiverTox. I'll search for the brand name of the supplement or the species.
Yeah.
And then often I'm just like left going off PubMed and seeing what's out there. Is there a better way or another resource for herbals specifically, or? No,
it's very difficult. You're right, because what happens is that the compounds have like these odd names, right? And then you have to get the actual label, and then you need to look at every single one, and then you have to think, okay, which one did this? It's just because there's just so many. That's the problem. Going forward, let's say we're trying to put more and more into LiverTox, and then we have our own network. We have a database where you can search a little bit more. But Jay just hasn't gone around to putting those in yet. Okay?
Great job.
Great, thanks.